Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
You can think about a workplace as a place that should be promoting the health and well-being of workers and obviously also promoting their safety. You don't want to work in a place that is unsafe from a physical standpoint or even a psychosocial standpoint. So those are absolutely the essentials, and that's what total worker health is all about. The interaction between health promotion, disease prevention, and occupational health and safety, they have to travel together. They have to be combination. You can imagine workers in a workplace, and you're trying to get them to quit smoking, but they're being exposed to toxic chemicals or odors or things that are really not very supportive of their health and safety. You can't ask them to do that if the work itself is toxic. So these have to be traveling together. Occupational health physicians need to be focused on chronic disease prevention, and things that people do, both at work and also at home, can influence their safety. Imagine people who are obese, or people don't have a proper diet, or don't get enough physical activity. They don't feel fit, they don't feel strong, they have high blood pressure that's uncontrolled, high cholesterol, they may be at risk for diabetes. These things really do influence your health, well-being, and safety at the workplace. So these things need to be traveling in parallel with one another.
Yeah, it's the safety, health, and well-being that I really heard in the session today. You had mentioned that you have a secret sauce as a way to kind of improve the workplace health culture and make it more healthy. Can you tell me about some of those?
Sure. So I've been studying, my team and I have been studying healthy workplaces for about 3 decades now. So we've had the luxury of going out and visiting many of the companies that have done this well. Many of those companies, by the way, have won the C. Everett Koop Award, which is an award given each year to organizations that can document that their programs have improved health and also produce a business purpose. They're, in many cases, a positive return on investment for their workers, and often that includes safety interventions. So I've traveled around the country, I've talked to people, I've talked to CEOs, I've talked to workers, to various people running these programs, and we have come up with certain themes that define best practices, as you call it, kind of the secret sauce for best practices. So let me just name a few things that we have discovered over time. Number one, you've got to have these programs embedded within a culture of health. It can't just be something that's plopped down or parachuted down on workers where the announcement comes out and says, well, tomorrow we're going to have healthy days. It's got to be part of the culture, part of the environment, part of where people are. In fact, one CEO told me, I want my workers healthier and safer at the end of the day than when they first came in. So culture that is there, its benefits, it's all the things that are important to create that culture. It's a way of being, not just a program. Coupled with that is senior leadership and commitment. And it's not just the CEOs and the C-suite people, but it's also the middle managers, the supervisors, the people who have day-to-day interaction with their employees. They have to buy into it. They have to support it. They need to see the value of having a healthy workforce. And those are kind of the key elements up front. And there are many other things that they do.
Can you give me another example?
Yeah, one other example is having clear goals and objectives to your program. In other words, you can't really expect people overnight to become healthy. They can't overnight start eating healthy, start exercising, quitting smoking, managing their stress. These are lifelong habits that have taken a while to get to where they are, where they're problematic. So why not set goals that are intermediate, things that you can accomplish in 12 months, in 24, 36, and then eventually down the road, you're going to get to those things that matter to the organization and to the workers themselves.
The other thing that I remember from your presentation was about evaluation, because that would be helping you know that you are moving towards your goals. And then there was some about incentives, but that seemed a little bit tricky about incentives. Can you speak a little bit about that?
Sure. Yeah, I'll start with incentives. I call them smart incentives. So there are a lot of dumb incentives out there, and I think many of them are actually counterproductive. The idea behind them is that if I pay you enough money, you're going to stop doing something that's pleasurable to you. For example, you're going to stop eating food that you shouldn't be eating, or you should stop smoking, or you should doing those things. And in some cases it works, but to some degree, but people are very suspicious about being paid to do things that ought to be good for them. You know, why is somebody telling me to do something that actually I should be doing on my own? So internal incentives are very, very productive, figuring out why people want to be healthy. And that's one of the key questions that I ask right up front. You know, why do you want to be healthy? Well, what's in it for you? And then bringing incremental incentives into play. So I'll give you an incentive to participate in the program. I'll give you an incentive for making progress, and I'll give you an incentive for moving along, but it may not always need to be financial incentives. In fact, when the money amounts get too high, they may actually be counterproductive, because people say, well, why are they paying me all this amount of money to do something? There must be something in it for them. So minor incentives to get your attention, to get you engaged, and to convert those external incentives into internal incentives is what works.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome, Dr. Shaw. It's a pleasure having you on our program. Thanks for having me.
We have a lot to talk about. We have a few patients that are going to be joining us a bit later, but I wanted to begin, if I may, Doctor, by having you please tell us what a vascular and interventional nephrologist is.
Sure. Well, I'm a physician that specializes in minimally invasive vascular procedures. The types of procedures that I do and that we at our team here at the Vascular Institute do include hemodialysis vascular access procedures, procedures for peripheral arterial disease, procedures for varicose veins or venous reflux disease, as well as other types of outpatient venous access and vascular access procedures.
And I understand you utilize minimally invasive techniques. Is that correct?
We do.
Okay. And what types of health problems would you say that these address?
Well, for patients who are on dialysis, we address their access needs, the vascular access needs. For people that have peripheral arterial disease, we address the diseases in their blood vessels that they have. And for people with the varicose veins or venous reflux disease, we address the refluxing veins.
Oh, very interesting. And now, what about venous access?
So for patients that require venous access, for example, patients that require a port or a PICC line, these are access to the bloodstream for patients that either require antibiotics or chemotherapy or medications.
Oh, okay. That's certainly good to know. And I wanted to follow that up by asking you if you can please tell us about the hemodialysis vascular access as well.
Sure. Patients who are on hemodialysis typically have a fistula, or a graft, or a catheter. And any access, regardless of what it is, can be problematic, and that's what we address.
So you take care of quite a few things in a very efficient and effective manner for your patients here.
We do.
And what would you say are some of the warning signs, Dr. Shah, that you may have an issue with regarding your access?
Sure. Well, one of the things we advise all of our patients that have a dialysis access is to examine the access every day, putting their hand on it. If they don't feel a buzzing, which we call a thrill, it's important that they call their doctor right away, and they oftentimes have to come and see us. There's other issues that can happen with that, and as patients recognize their access, they'll notice that sometimes it feels different, or it's maybe red or inflamed or something like that. Those are the types of situations that we ask our patients to look out for, and if there's a problem, to give us a call.
And can you tell us more, Doctor, about the peripheral arterial disease that you mentioned earlier?
Sure. Peripheral arterial disease is a disease of the arteries that predominantly affects the lower extremities, the legs and feet. Some of the risk factors that predispose people to PAD is diabetes, high blood pressure, high cholesterol, smoking, and advanced age.
Are there any symptoms related to PAD that we need to be aware of or watch for?
Sure, absolutely. So as far as symptoms are concerned when it comes to PAD or peripheral arterial disease, the first thing that patients commonly complain about is exertional pain. So if they start to walk a block or two or three or four, they may notice that their legs get tired or become painful and they have to stop. As the disease progresses and gets worse, that pain happens with less and less exertion until sometimes that pain happens even at rest. Some people then develop ulcers that don't heal or heal quite slowly because they're not getting enough blood supply. That can also be associated with a discoloration of that part of the leg. And ultimately, this can lead to infections and amputations.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.